All right. Hi, everyone. This is so great that this is a completely online Sydney Health Ethics conversation series. I think we have not had any complete online conversation series. Anyway, so this is really great that we are having today Pat McConville. And before Pat takes over, I would like to acknowledge that we are on the Gadigal land of Eora Nation, and then we respect all the past elders and continuing and emerging scholars and Indigenous scholars. And I also acknowledge that anti-colonial struggles have been going on forever, and it is present, and it makes us to think through about what bioethics is in this kind of the world which we live in right now too, right? As we think. So, but at the same time, I'm so excited that we have here Pat today with us, and Pat would be talking on phenomenologically informed consent. Is it possible? That's like so exciting, and I'm curious really to look forward to listen to you more, Pat. So over
I'm
to
curious
you.
about it too. Thanks so much, Supriya. Hi, everybody. Thanks for calling into this presentation, and thanks for making this virtual seminar possible, Supriya and the SHE team. I really want to thank you for inviting me to be part of this. It's so great to be part of, to join Sydney Health Ethics, which is really a centre for Australian and Australasian bioethics and health law. So it's exciting to be part of this kind of community and broader community. For those of you who don't know me, my name is Pat McConville. I'm a philosopher and bioethicist. I'm currently engaged as a lecturer with the Ethics, Law and Professionalism team at Deakin University School of Medicine. And I also do some casual work with philosophy at Deakin and some medical ethics teaching at Monash University, where I completed my PhD last year. Although I work at these Victorian institutions, I'm actually based in and calling in from Wilwanina country around Nipaluna, Hobart in Latruwita, Tasmania. And I want to start, Supriya's already done a very fine job, but I want to also acknowledge the traditional custodians of the lands on which we're meeting. Many or most of you are on Gadigal country, and I want to acknowledge the elders and ongoing custodians of those peoples. Australian Aboriginal people are part of the oldest continuing culture in the world, and sovereignty was never ceded. This always was and always will be Aboriginal land. I was so pleased when Supriya invited me to join this seminar series late last year. And at that time, my next few months were pretty uncertain. I'd been preparing for my third major open heart surgery. I accepted Supriya's invitation and resolved to think about what I would actually speak about a bit closer to the date. Things didn't really get much more certain until after my surgery, which was in January. So I decided, rather than kind of come up with something brand new, to bring together some undeveloped threads that have been with me for a few years. And so I landed on the topic of whether a phenomenologically informed consent is possible. So my plan for this presentation is to first talk to you about what my motivation for thinking about this issue is, then to have a quick look at informed consent as it is at the moment. I'll consider a couple of kind of initial challenges to a phenomenologically informed consent. And finally, I want to draw on my doctoral work on artificial hearts to give you a kind of proof of concept of how a phenomenologically informed consent might be structured. So to talk to you about my motivation, I hope you will indulge me with a little bit of backstory. I was born with a single ventricle heart condition called double inlet left ventricle. I had a complex pediatric surgery called a Fontan procedure when I was 2 years old, and I've lived in contact with the health system all my life. And if you're interested, I wrote about my experience of congenital illness, or the experience, I should say, of congenital illness using my own experience as a case study in a paper called Towards a Phenomenology of Congenital Illness, which was published in Medicine and Healthcare a few years ago. Sorry, Medicine, Healthcare and Philosophy a few years ago. At the age of 26, that's about 11 years ago, my cardiologist informed me that it would be necessary to undergo a second open heart surgery called a Bentel procedure to address an aortic aneurysm. A Bentel procedure involves the replacement of the aortic root and stem. And in my case, it involved the insertion of an artificial conduit into my aorta. And it also involved the replacement of my existing leaking aortic valve with a new mechanical valve. The preoperative process for this surgery was pretty straightforward. When it came to give my consent, my partner and I sat down with a cardiac registrar, surgeon, and anaesthetist and went through the risks. Risk of injury, risk of death, risk of medical complications. My partner was there when I woke up in ICU, and one of the ICU nurses turned to her and asked, "How will you go with that noise?" "What noise?" "The ticking." Unbeknownst to us, the mechanical valve produces an audible, in fact, quite a loud ticking noise as it opens and shuts in line with a person's heartbeat. The ticking of a mechanical valve is well known to any cardiac care professional, but nobody had mentioned it to me, the patient, or to my family. I have a history of arrhythmias, most of, but not all of which are benign. I, and especially my partner, are alert to my heartbeat doing funny things. With every heartbeat amplified and announcing itself to us, the next few months and years were lived in a state of heightened vigilance. Even when I was medically well, we could not ignore this kind of constant reminder of possible danger. This was a phenomenal, and as we go on, I'll use the terms phenomenal and experiential kind of interchangeably, but this was a phenomenal effect predictably brought about by a medical procedure. It changed the way that we felt and lived. It wasn't disclosed because it wasn't a medical risk, and it has no bearing on my health, at least kind of narrowly construed. But it would have been nice to know. I don't know that it would have changed my mind about what I would have done in regards to this procedure. Maybe, maybe not, but it would have been nice to know. I won't talk too much about informed consent generally, because I think there are plenty of other folks more learned on the topic here and at SHE. But informed consent was something of a revolution in medical ethics. It involves the idea that patients ought to consent to any medical intervention administered by a clinician. And not only should they consent, they should have a good idea about what they're consenting to. It puts the patient's judgment at the centre of the clinical interaction rather than just the doctor's. Australia is pretty typical of a Western model of informed consent. So I've got the 4 elements of informed consent down there on the slide. It involves ensuring that a patient has the relevant capacity to make a decision about the intervention, that consent is given voluntarily without coercion, that consent is specific to a particular intervention or course of treatment, and that it's informed. And it's this last element of information which is interesting to me in what I want to discuss today. For a long time, what information a patient should be given by a doctor was subject to the Boland principle. That is, a doctor should disclose to a patient the kind of things that other doctors would disclose in a similar situation. They're negligent if they don't meet this standard. This is a standard that still persists in other aspects of medical negligence, not related to disclosure or information. This means that the doctor, rather the collective profession of doctors, decide what a patient ought to be told on the Boland principle. But a little over 30 years ago, the Australian courts adopted a new principle. A 1992 medical negligence case revolved around a patient with vision only in one eye who was not told of a remote risk of losing their remaining vision as a result of an intervention. The courts found that such a risk, however remote, would be material to that patient, that a reasonable patient in that position would be likely to attach significance to it. Not that it would change their mind or affect their decision necessarily, but they would have expected to be told. Rogers v. Whitaker ushered in a new standard for informed consent in which doctors are required to consider the patient's situation when disclosing information. So no longer does the doctor decide what is relevant. In theory, at least, the patient's situation determines the duty to disclose. But even with this kind of perspectival shift, what is considered relevant remains within medicine. Doctors disclose the kind of medical risks that a patient might be concerned about, but this is still medical information. But medical interventions also produce changes which are significant but are not obviously medical in nature. I've given you one example of this mechanical heart valves ticking already, but I'm sure we could also think of other things, an intervention which is time limited, which gets you thinking about time differently, a medication which changes your tastes or senses. Some of these are already kind of considered medical and are disclosed. Some experiential factors like predictable mood changes are disclosed, particularly in the case of kind of mood-altering drugs or interventions. But this is already kind of variable. So open heart surgery patients, for example, are often told how to manage blue feelings that come about as a result of the intervention with their heart, but they're often told after surgery, not before. There's no disclosure of that stuff. That's a kind of a medical management problem to be dealt with after the procedure. Mostly what is disclosed are things that are quantified or quantifiable or conceived within the domain of physiology, things that doctors care about, but not necessarily everything that a patient might care about. So why not disclose phenomenological risks or effects as well? Well, one reason that we might hesitate to include phenomenological factors in the duty to disclose is that it's just such a broad category. There are an almost endless number of variations among people, resulting in different priorities and different concerns. And more importantly, there are endless variations in the ways that people experience things or can experience things. Differences in how people undergo experiences based on infinitesimal subjective differences between people make it extremely challenging to predict if and how an effect might be experienced by a patient. And of course, this kind of broad set of questions has been a problem forever in the history of philosophy. It's a metaphysical, ontological, and epistemological problem, which has spun out into everything from radical skepticism about other minds to kind of thinking through a philosophical anthropology about what it is that makes us all human, or what it is to be human, to phenomenology, which is kind of my area of interest. I do think that phenomenology gives us some guidance about kind of being in a world already among other people and other subjectivities to whom we can and do relate. There's a fundamental intersubjectivity in the way that we relate to people. And one approach from phenomenology, the phenomenology of Maurice Merleau-Ponty, who I principally work in that tradition, is to think about intercorporeality as a thing that unites us and unites our experiences, that we all have bodies. A feminist interpreter of this concept, Sonia Crooks, talks about a shared concept of pain that might unite us. And non-phenomenological feminists have long talked about the kind of mutual vulnerability of being that it is to be in the human condition. But let's put aside that kind of metaphysical, ontological question for a moment, because in the end, I don't really have any clue how to resolve the problem of intersubjective difference. Whether when I see blue and you see blue, we're seeing the same thing, I don't necessarily know how to resolve that question. But I do want to claim that medicine already deals with this within medicine. Uncertainty and difference is part of medicine. The truth is, doctors don't know, or know only in kind of high level or maybe medium level terms, depending on how generous you want to be, how an individual will react to a particular intervention. Medicine makes the best guesses based on empirical data, clinical trials, all that sort of stuff, or medical research, and discloses the risks that may or may not occur to a particular person after an intervention, from common risks to kind of rare risks or side effects. And importantly, medicine discloses those risks in line with Rogers v. Whitaker, based on a judgment about whether they are material to a particular patient. So that kind of situation of the patient is already taken into account in the concept of informed consent as that it is. Medicine is already interested in this kind of data. And I think that medicine could as well be interested in experiential data. Another problem, apart from kind of just the difference between people, a more kind of firmly epistemological problem, is the issue of transformative experience and communication. A medical intervention will alter a person. The things which are significant to them prior to a procedure may be different to the things that are significant to them after a procedure. In fact, their past or future concerns or experiences might not even be comprehensible to their self on the other side of the intervention. L.A. Paul gives the dramatic example, literary example, of the vampire. Becoming a vampire might be absolutely unthinkable to a human, but once you're a vampire, it's absolutely unthinkable that you once didn't lust for blood or that you feared mortality. Those things might be so foreign to you now that you're a vampire that it's hard to get your head around that experience. A more relatable example, perhaps, might be being or becoming a parent. It's hard to communicate the love and the exhaustion that a parent feels talking to a non-parent. So there are problems of communication of experience. How do we make experiences, the consequences of interventions, intelligible to people facing decisions about those interventions? One quick response, I guess, is to say that medicine isn't making vampires. Rarely are the experiential conditions before and after a medical intervention so far apart as to be totally incomprehensible. But there's also a very useful literature on how to communicate experiential knowledge. A colleague of all of ours based at La Trobe named Yuri Kath works on how to communicate what it is like knowledge through testimony and description. Such knowledge may not be conveyed perfectly, but I think we can probably do a passable job that would help us get closer to a phenomenologically informed consent. The final challenge that I want to consider today is about the authority or responsibility of doctors to speak about non-medical effects of interventions. One might object that it's not a doctor's job, nor is it their place to tell a doctor tell a patient how they will experience their own life. It might even be problematic for a doctor to seemingly enter into the world of ethics rather than medicine. I'm sympathetic to this objection. Doctors already command tremendous power and privilege in therapeutic settings. Setting them up as kind of the fount of all knowledge, even outside the strictly medical, may be a problem. But at the same time, they're the ones principally responsible for the intervention. They have the privilege and the burden of obtaining consent. They're in charge of that process. Bioethicist and disability rights scholar and advocate Adrienne Ash, who many of you will be more familiar with than me, objected to the fact that doctors and genetic counsellors would advise prenatal testing and frame the results in terms of medical outcomes, disease, and disability. This would tend to obscure the lived experience of people with genetic conditions and their families. Gone were the joys, triumphs, and positive experiences of children and parents. Gone also was discussion about support and community. So Ash recommended that genetic testing be accompanied by information about the lives of people with genetic conditions, not just the medical data. That information might be conveyed by healthcare professionals, it may or may not be written by them, or it might be conveyed by families themselves and patient groups based on their experiences. There is also, I think, an opportunity to engage patients and families in a phenomenologically informed consent more broadly than genetic testing. There's also a growing literature on epistemic injustice in medicine and healthcare. Philosopher Miranda Fricker has suggested two types of injustice: epistemic injustice, hermeneutic and testimonial injustice. Hermeneutic injustice occurs when people don't have the linguistic tools, the words, to communicate their experiences. Testimonial injustice is when people's accounts of experiences just aren't taken seriously. And I think that bringing phenomenology into healthcare at an earlier stage might help to address these systemic injustices by validating and acknowledging people's experiences. I've been talking about phenomenology in a couple of different ways so far. So what is phenomenology as an approach? Well, when I say phenomenology, I mean the study of experience, or more particularly the study of the conditions of experience. Phenomenology considers rich descriptions of experiences, then it considers real and imagined variations on those experiences, and ultimately it tries to pick out essential or structural features of those experiences. So I mostly work in the tradition of Maurice Merleau-Ponty, of phenomenology of body, but phenomenology has also been used extensively already in healthcare, especially nursing and psychiatry, but also increasingly somatic medicine. And I did my doctoral work on artificial hearts. These are medical device interventions for end-stage heart failure. I chose some important phenomenological structures identified in the purely philosophical literature and tried to map these to the literature on artificial hearts. That literature included medical, engineering design, and patient perspectives. And what I came up with were three key axes of phenomenological, not medical, change that having an artificial heart might bring about. These axes were incorporation, one's sense of their own body, temporality, how one perceives and relates to time, and motor intentionality, how one engages with and relates to the world. I put possibly the biggest dimension of change, intersubjectivity, how we relate to each other, to one side because it was just too big for my project. And I wouldn't necessarily recommend it, but you can find my dissertation on the Monash University Library website if you want to. But I do like to think that I made some interesting findings. For example, I suggested that the absence of a heartbeat, because some of these artificial heart devices don't beat, they spin, and that's quite different. That might change the way that people experience time. Or that, for example, constantly being presented with your cardiac output in hard numbers on your controller's LED, you've got a little computer that you carry around that says what your cardiac output is, might be a bit distracting or induce a kind of metrogenic anxiety, a worry produced by constant measurement. But the investigation that I did in my PhD was specific to this particular intervention. And it might be that we need to think about the phenomenological structures which are affected on an intervention by intervention basis, or maybe on the basis of categories of intervention, specialties. Incorporation, for example, will be relevant to all implants or transplants. And there's a huge literature already about living in cancer prognosis. So temporality is probably a big feature of cancer interventions. All of this sounds like a big task, and it is, but I think medicine is already doing this just on physiological rather than phenomenological content. So I don't really have a model or a proposal for phenomenologically informed consent. It already happens in some places. My GP, for example, talked to me about how heart surgery has a deep, existential, subjective, transformative effect before my surgery in January. But neither my surgeon nor cardiologist said anything like that. They went through the statistics, not the experiences. But my cardiologist did offer to connect me with other patients who had undergone the same procedure. So there is, I think, some recognition that medicine and healthcare is bigger than the discrete sort of intervention. And that if we're going to think about what is significant to a patient, we have to think outside the clinic as well. Thank you.